So the rationale is to propose the best option for the patients with diffuse large B-cell lymphoma previously untreated. And we know that Odronextamab could be potentially superior to rituximab, as Odronextamab demonstrated previously in the context of relapsed refractory diffuse large B-cell lymphoma, accompanying efficacy. And so we know that also from a rational and scientific point of view, Odronextamab and rituximab could share the same potentially tumor targets on CD20. And so the objective of the study is to offer the best treatment to target CD20 in frontline treatment and potentially to replace rituximab with Odronextamab. For the safety part, so we do not observe any significant signal of toxicity with this combination of treatment. So we observe what we know with both agents of chemotherapy or bispecific treatment, and especially, for example, we have observed some CRS in 54% of the patients. That was expected with Odronextamab and bispecific in general, and there was no significant higher toxicity with Odronextamab as compared with other utilization or other clinical studies. All the CRS, for example, were grade 1 and 2, and there was no ICANS, no TLS in the protocol. Yes, and for the efficacy, so we have evaluated two different dose levels. Dose level 1, 80 milligram, and dose level 2 was 160 milligram for the full dose of the treatment. And before that, step-up dosing was given to the patients to improve the tolerability of the treatment. And what was interesting is to observe 100% of complete remission rate at the dose level 2. So this means that the dose level 2 was selected to continue the next step for the protocol. This is a big question. So I agree with your comments that the possibility to replace rituximab by Odronextamab is now feasible because we have now these first results of the study with 100% of complete remission rates in patients with diffuse large B-cell lymphoma, high-risk patients, and they do not receive rituximab. They were treated with Odro plus CHOP, and we observed 100% of complete remission rates. So it's now possible to say that we could potentially replace rituximab with bispecific Odronextamab. Yes, so we have some biomarker results in two parts of in two information. So the first is a B cell panel, and we observe the complete depletion of B cells after the first dose of Odronextamab, meaning that the treatment is really associated with a profound effect on B cell, and we have observed that the B cell count is 0 during all the treatment duration. So meaning that the activity of the treatment is confirmed by this biomarker. The other biomarker is the T-cell margination, and we observe a T-cell margination after the first dose of the treatment with a dip of the T-cells. And so it was important to confirm that the margination of T-cell is also associated with the efficacy of the treatment, as we previously observed with other studies. So association with Odronextamab and chemotherapy is also confirmed to have some margination in the population of patients, and so it's a biomarker of pharmacodynamics.